Hello, welcome everybody. This is the Community Opioid Symposium. This is the webinar Opioid Tapering. Dr. Corey Hayes will be presenting. This is a free educational event brought to you by the Louisiana Department of Health, Office of Behavioral Health, Acadian Area Human Service District, and Women's Foundation. The purpose of the Community Opioid Symposium is to increase awareness and education for prevention and treatment of opioid use, misuse, and abuse. For information on future presentations of this series, please visit womensfoundation.com/COS. This session is credited for 1 hour for social worker, licensed professional counselors, ADRA, and AMA PRA Category 1 credits. Full participation of this presentation is required to receive credit and will be monitored throughout the session. After the event, you will receive an email from Women's Foundation with detailed instructions on how to claim your credits and access your certificates. Dr. Corey Hayes has no financial disclosures. Dr. Hayes is a clinical pharmacist, epidemiologist, and addiction health services researcher. Dr. Hayes uses population-level claims and electronic health record data and advanced quantitative methods to improve prevention and treatment of substance use disorders. His work focuses on improving policies related to opioid prescribing and developing technology-based interventions for improving treatment of patients with opioid use disorder. So without further ado, I'm going to turn over the camera and the mic to Dr. Corey Hayes, and we will begin our presentation.
All right. Well, good afternoon, everybody on the Central and Eastern time zones, and for the Mountain and Pacific time zones, good morning. Ashley, Amy, or Janie, would you mind? So while I'm in presentation view, I cannot see the chat. So feel free, anybody who's joining, feel free to interrupt me at any point in the presentation or post any questions in the chat feature. And if Ashley, Amy, or Janie, if one of you will stop me if there's a question in the chat so we can go ahead and address it in real time. I just can't see it when I'm in the presentation view with the slides. So feel free to let me know that there's questions in the chat. So we're going to talk about opioid tapering today and a little bit of the intricacies of how to do it. There's a whole nother lecture that could be done on this topic in regards to how to get your patient motivated to decide to opioid taper. But that's not really what we're going to focus on today. We're going to focus on from when you get the patient motivated, what do you do from there? And like I said, the whole motivation thing is a whole nother presentation that includes a lot of motivational interviewing techniques. And so that is another great topic to cover at some other point in time. But this is going to focus on once you have the patient motivated, what do you do after that point? So we're going to identify the evidence-based practices around tapering opioids among those patients who are using opioids chronically or long-term. And I say evidence-based practices, it's really what we have currently. There's a lot of research going on in this realm of opioid tapering. How do we do it well? How do we do it safely? And a lot of that research is ongoing. And so we don't have complete answers yet, but I'll try to give you the best that we've gotten so far. We're going to also describe the currently available tools used for busy clinicians in opioid tapering. What are the tools out there, templates, toolkits, etc. And then we're also going to discuss some patient cases for tapering. So as Ashley said, I have no financial disclosures for this talk. So I am going to try to make it a little bit more interactive than you know, the pandemic has made it hard to be interactive in general, but I'm going to try to use some technology to make it a little bit more interactive. So what I'm going to use is Poll Everywhere. And so if you bring up your phone, the number I want you to text to is 22333. So hopefully you can see my browser, my arrow pointing to what number you're texting to. So 22333 is the number you're going to text to. And in the body of the text, you're going to put Corey Hayes, all one, 359, and you're going to hit send. So this does not track your number. It does not send you spam information. It is simply joining a poll so that you can answer some questions. So when you hit send on this message, it's going to come back to you and say you've joined Corey Hayes's poll or something along those lines. So I'm going to leave this up for a second just to make sure everyone has this information before we move to the first poll question. And if you can't get this to work, you can certainly put your information in chat. And if Ashley, if you don't mind to let me know in chat if anyone's posted in there, that'd be great. Okay. Okay, so here's the first poll question. I just kind of want to get a sense of who's joining today, what your training background is, so I can kind of tailor it a little bit as needed for this. So if you don't mind, so you should have the poll up where you've texted to the 22333 and put the Corey Hayes 359 in, sent that. Now you can just answer with answer options A through G, which correspond to the different ones you see there. This one's taking a while to load. Okay, there we go. Just takes a while to load. Okay, so most are other. 4% nurse practitioner, 17% licensed clinical social worker, 13% LPC. What are some of the other, if you don't mind, some of you who put are the other, would you mind to let me know in the chat feature what other is represented here? Obviously, I didn't do a good job with my categories.
So some of the others, we have peer support specialist,
Okay.
addiction counselor,
Okay.
epidemiologist, licensed addiction counselor, RSW, registered social worker,
Okay.
LAC, ADRA, prevention specialist, parent support group. It looks like anybody else that we're missing? Opioid outreach coordinator.
Okay.
LPP, licensed prevention professional.
Okay. So wide range of participants here. So that's good. So this helps me because I kind of tailor it a little bit when I'm talking to prescribers. And so this is very helpful. Thank you very much. Oops.
And you do have a physician who just joined.
Okay, perfect. Okay, so this one is kind of open response. What is the biggest barrier to tapering and or discontinuing chronic opioids in your clinic? So whether you're seeing these patients as the prescriber or you're associated with the clinic, let me know, what do you think are the biggest barriers that these patients face? And so if you're just joining, we're kind of making this a little bit interactive via the phone, via your cell phone. So you can text the number you're going to text to is 22333. And what you're going to put in the text in the first text is Corey Hayes 359. You'll hit send. It'll say joining the poll. And then you can text in free text this one to answer this question. Okay, so trauma-informed support structure, right? So dealing with some of the things that opioids are masking in all of that, whether it's trauma, masked depression, etc. Withdrawal symptoms, certainly we're going to talk about those and how to treat those. Rebound pain, it's a big problem in which a lot of patients think that they will face. Getting clients to be consistent and coming to the clinic to actively participate, yes, this is certainly a big deal. Tolerating physical symptoms, the withdrawal symptoms, I'll loop those together, right? Addiction, yeah, so if they have, as you're tapering, if you realize, or even before you taper, that they have an opioid use disorder, that's another situation of switching them over, and morphine milligram equivalence becomes important, etc. Patient willingness to taper, yes. So we talked about the fact that there's a whole nother lecture that can be done on how to get them willing to taper, which is a big deal. All right. Okay. So let's start off talking about when should you consider tapering a patient. So what are the red flags or things that should strike you when you are trying to figure out who would be the best candidate for tapering? So this is according to the CDC, and I try to post all of my sources down at the bottom of each slide so you know where it's coming from. But this is from the CDC and what they recommend on kind of things that should strike you as potential times in which you might want to consider a taper for this particular patient. So first off, if the patient isn't experiencing a clinically meaningful improvement in their pain and function, and most of the time what the CDC is going to recommend of using for measuring this is the PEG scale. And a clinically meaningful improvement in the PEG scale is about a 30% improvement. So we'll look at the PEG scale in the next slide and what it looks like and how to score it. You should consider tapering if the patient's on doses of greater than 50 morphine milligram equivalents per day, or if they're on benzos. So if they're on high doses without a lot of benefit, or if they're on opioids and benzo combos, this is a good area in which to consider these patients for tapering. If they're showing signs of substance use disorder, so go back to your DSM-5 criteria for this. Are they showing signs of work or family related problems in relation to their opioid use? Difficulty controlling use? Are they constantly out early? If they've experienced any overdose or other serious adverse event, that it may also be symptomatic as shown up as slurred speech, sedation, confusion. Those are all indications that this isn't going as well as you'd hope for this patient. So these may be times when you want to taper. And I will say for the last three there, you're probably going to really want a diagnostic workup for an opioid use disorder, whether or not they need to be transitioned over to buprenorphine, etc. So as promised, here's the PEG scale. So this was developed by Aaron Krebs out of the University of Minnesota, and it's simply 3 questions. And really the point of the PEG scale is to focus not just on the pain intensity level. So most of the time when you're thinking about what is done in a clinic or hospital setting, you're just focusing on question number 1 of this pain scale, of the PEG scale, which is about pain intensity. And in fact, actually, this PEG scale does a little bit differently, where they ask about the pain over the last week for each of the 3 questions. So what number best describes your pain on average in the past week? And so for each of these questions, you're using the 0 to 10 scale like you would for the numeric rating scale. So 0, no pain, 10, as pain as bad as you can imagine. Number 2, what number best describes how during the past week pain has interfered with your enjoyment of life, and then how that pain has interfered with general activity in question 3. So 0 to 10 for each of these. The max score is 30. So if you think about a 30% decline in this, so if you give it to the patient when you start long-term opioid therapy, and then you give it to them a couple months later, you know, if their score was 30, think about what's 30% less than that, and that's what you're targeting for clinically meaningful improvements in their pain and function. So if they're not meeting that, that's a good indication that maybe the benefit of the opioid regimen isn't outweighing the risks. So this is another visual that I liked when I was preparing this lecture on when to consider tapering for patients. And this is according to the VA. So we've looked at what CDC says. Now this is within the VA system. There are a lot of similarities between when the VA recommends tapering as compared to the CDC. So you can see up here in the top left corner, no pain reduction, no improvement in function. So talking about the PEG scale there. Concerns related to an increased risk of SUD, behaviors, family history, or an overdose event. Concomitant use of benzos that increase the risk, or non-adherence to the treatment behavior plan. But there are certainly things that are a little bit different from the VA's visual versus the CDC's guidelines. So one is this severe unmanageable adverse effects, such as the drowsiness, constipation, cognitive impairment. So if they're experiencing these, or if they're on doses greater than 90 MME per day, those are kind of the some points that VA bring in, and difference in dosage cut scales, where we saw 50 with CDC, 90 with VA. So a few differences there. Also, the VA brings in some differences in medical comorbidities. So if your patient has lung disease, sleep apnea, liver disease, renal disease, fall risks, these are all things in which you might want to consider tapers. The issue with lung disease, sleep apnea, of course, is around the risk to respiratory depression that opioids have. So if you have any underlying conditions that are also creating issues with respiratory depression, you want to try to consider tapering opioids. Liver disease, renal disease, those two things are just thinking about how the opioids are eliminated from the system. So either via the cytochrome P450s in the liver or via filtration of the kidneys. And so if either of those have disease states, then you're going to have longer times for the active metabolites in the body. So this can be a problem. Fall risk, of course, opioids increase the risk of that. So if they have any underlying issues around falls, also a time in which to consider tapering opioids. And then lastly, because it's a bigger deal in VA population specifically, mental health comorbidities that can worsen with opioid therapy. So we can certainly see masking of depression symptoms, masking of PTSD and anxiety symptoms when using opioids. So even before, so let's say you're now to the point of my patient is one who could benefit from tapering, or at least meet some of these requirements, or you know, kind of the things in which you might be flagged for considering tapering. So even before you start the tapering regimen, there are certain things that you've got to do before you even begin that journey. So some of the things you want to screen and maximize before tapering include maximization of treatments for mental health disorders. So there has been a study out that's showing that post-tapering depression scores is the sole driver of whether or not the patient can effectively get off opioids. And so this is, you know, generally thought to be that we're starting to unmask the symptoms of depression that are underlyingly there when you start taking opioid dosage down. So you certainly want to maximize treatment of depression, anxiety, PTSD. OUDs or other SUDs, so this may change completely the treatment plan that you have in place. So do you need to switch them over to a SUD clinic? Do you need to start buprenorphine? Those types of things. Moral injury kind of falls under the bucket of what happens with other mental health disorders. So if a patient is really struggling with moral injury, and sometimes this can be a bigger deal within the VA system, then this is also something that you want to work through before you start exacerbating those symptoms as they start to come off the opioids. Central sensitization, so such as fibromyalgia, chronic headaches, these are disease states in which opioid therapy isn't all that great for anyway. So you certainly want to maximize treatment of that before you start the decrease in dosages. Medical complications. So we're about to send the patient, as we're tapering down, we're about to increase some of the risks of them going back on previous doses. So you want to make sure that whether it's diseases that change the elimination of the opioid from the body or increase their risk of respiratory depression or falls, that you want to maximize treatment of those and decrease the risk of those before you start the opioid taper. Okay, so let's say you've decided that this patient is a good candidate for taper. You've done the magical work of getting them willing to do the taper, and you've now maximized the treatment of all those other comorbidities and conditions that need to be maximized before you start the taper. So now you're to the point of doing the taper. So how to do that, you need to go slow, usually 10% decrease in their dosage or slower. I would particularly lean towards a slower option than that. And we'll look at several options here in a second. Consults, who do you need? Do you need a psychiatrist? Do you need a sleep study? Do you need any other mental health providers who might provide the support? And also within support, do you need the naloxone, either through a standing order or prescribing it to them, education around naloxone, and then encouraging the patient. So this takes a lot of time. So in the VA system, they use pharmacists a lot to help the prescribers in tapering patients. But you're going to have to rely on several different disciplines and professions to help with patients for tapering, because it's not going to be all inclusive in a 12-minute visit with the primary care physician that you're going to be able to accomplish this well. So encouragement is going to take time. You need to talk to the patient about what the literature shows that you can probably increase your function in the tapering versus what you think might be the case of increased pain, decreased function. So educating the patient around that and encouraging them that this might be best for them in the long term. So the strategies that you're going to use in tapering are basically going to be three things, and you're going to do it with every visit. So you're going to discuss with the patient, how's it going? Where are the roadblocks you're experiencing? You're going to ask about their goals, and we'll talk about goals here in a little bit more in just a second. And then you're going to continue to educate, probably cycle through these three things with each of the visits that you have with the patient. So first, discussion, you're going to, listening to the patient's story, getting their buy-in is what you're trying to do here. And you're letting them know that you believe that their pain is real. If you don't, then probably be thinking about substance use disorders. Including family members and other supporters in this discussion. So the patient, once they leave the office, is going to have to rely on others. So is this a peer support specialist? Is this family members who might be going along this journey with the patient? And this becomes really important. I know we had one patient who was tapering down, and we wouldn't have realized that the patient also struggles with some of the other medications that we might have added. So for example, we were tapering down opioids and considering going to go to gabapentin. Well, if we hadn't talked to a sister of the patient, we wouldn't have realized that she also has issues with gabapentin abuse. And so this is something that the right family members can be good support structure for the patient. And then acknowledging the patient's fears about tapering. The fears are real, but the literature that we're showing is that it's likely that you're not going to have the effect in the taper that the patient thinks they're going to have. It's probably not likely that they're going to increase their pain, that they're going to decrease their function. It might be actually the opposite or no change. So talk to them about that. Talk to them about some of the literature out there that we do have, and hopefully you can get their buy-in. Okay, so discussion, asking about the goals, education. So when you're specifically asking about the goals, what you want to do is draw out their goals for their life. So I typically, when I'm doing this with a prescriber, we typically tend to phrase this as, what are the things that you want to do in your day-to-day that you currently aren't doing? It's rare that we would ask about their straight up pain amount. And that will come into play. The patient will probably bring up their pain intensity. And that's where you can certainly incorporate discussions about, I'm probably not going to get you to a 0 24 hours out of the day. But if I can improve your functionality in this process, would that kind of outweigh some of the stability and pain? You know, I may not improve your pain intensity, although I might. Is the functionality going to outweigh some of the pain that you're still going to experience? So, you know, for some of the elderly individuals, this might be, I want to go see my grandson play soccer. I'd like to sit on those hard benches without feeling like I'm going to have to lay in bed for the next day. You know, I'd like to work in my garden, or different things like that. And so here is a link to the personal health inventory that the VA has created for getting a sense of what are the patient goals. And so then wrapping the progress of the tapering around those goals. So are we improving and working towards your goals as we do this taper that aren't necessarily attached to being pain-free? And then asking how you can support them during the taper. What is the biggest thing that they need throughout this process? And then finally, educating the patient and incorporating other techniques as you taper. So offering physical therapy, complementary and integrative health. So acupuncture, meditation, yoga. You know, there are some people who are just not going to do the meditation and yoga, but maybe they'll try the acupuncture. So offer them an array of options and see which ones that they might bite at. And then non-opioid pain medications. So I talked about, for one patient, we were thinking about gabapentin. So do they have neuropathic pain? Maybe you can add that. Is it localized? You might be able to do some of the topicals. So, you know, Voltaren just went over the counter. So maybe they can use that if it's an arthritic knee or something along those lines. And then providing overdose education and prescribing naloxone to patients who are at increased risk. So this becomes vitally important. I don't know if I can stress this particular point enough, but as the patient starts to taper, so as they start coming down, this is where you will find the greatest risk of overdose for these patients. So when they start coming down, their tolerance will start changing. So what they may have tolerated, what might not have suppressed their lung function previously, in a week may be different from now versus when they were on it a week ago. So as you start coming down in dosage, as these patients start coming down in their dose, their tolerance is going to change within a week's time. And so a lot of these patients think that they can, if they're having a really bad day, well, I'll just go back to my original dose. That really worked for me. I'll just go back to that for today. It won't be a problem. And that's when the risk of overdose increases. So you really want to educate the patient around this point. Please, please, please do not go back to your original dose. Your tolerance is going to be different. Your lung function is going to change, or you know, your lung tolerance to that to the suppression of the opioids is going to change. And so I can't have you going back to your original dose. And this is where either prescribing the naloxone, telling them about the standing order, from the pharmacy, whatever it is in your particular state becomes important. So in Arkansas, where I'm based, we have a standing order under our Secretary of Health, who's over the Department of Health. So within that, any pharmacist can technically prescribe under the standing order naloxone to any patient who's deemed to be at risk. So if that's the case in your state, maybe you want to go ahead and write the script, or maybe you just want to tell them, go to your pharmacy. It's either over the counter or it's in a standing order, something along those lines. So think about what your policy is in your particular state. And then it's really important with the naloxone that the patient not only understand how to administer the naloxone, but that the patient also has someone who's living in their household who understands how to administer naloxone and where they're going to store that naloxone. So it's kind of pointless if the patient is the one at risk, they overdose, and no one in the household knows that they have the naloxone or where it is or how to use it. So we need to make sure that you're telling the patient, whether it's you're seeing them in an office visit, when you're going to the pharmacy and picking this up, make sure that the pharmacist educates not only you, but whoever is living with you to know where you're going to store this and how to administer it so that you have someone else on hand who can do those things, should it become necessary. Okay, so this is a very busy slide, but this is also from the VA. And what the VA did is they cut down into different sections the rates of tapering. So they consider, I wish they'd named this better, but what they call the slowest taper occurs over years. The slower taper occurs over months to years, faster taper over weeks, and then a rapid taper over days. So they cut it down into 4 different categories when you're talking about tapers. The slowest taper is reducing by 2 to 10% every 4 to 8 weeks with pauses as needed. The slower taper is the most common and the most widely accepted to be used. And with it, you're going to reduce by 5 to 20% every 4 weeks with pauses as needed. And the faster taper reducing by 10 to 20% every week. And rapid taper by 20 to 50% with the first dose, and then reducing by 10 to 20% every day. So the rapid taper is the one you're going to see more on the inpatient side. And hopefully the slowest or slower taper are the ones you're going to be using on the outpatient side. The faster taper you might use if you're concerned about the patient's risk, but you're also really monitoring during this time frame. So even with these faster tapers, you're going to start increasing their risk of overdose. But if you are concerned about them having the opioids on hand, you need to make sure you're monitoring, checking in with them very frequently. Okay, so, and then what this slide does is give you a sense of how these tapers play out over time with the same regimen. So for example, morphine SR 90 milligrams every 8 hours. So this is 270 morphine equivalent dose. And it's showing you how long it's taking to get there, to get dosage reductions for each of these regimens. So with the slowest taper, they went from, the original dose was 90 milligrams every 8 hours. So they stuck with 90 in the morning, went down to 75 at noon, and then 90 again in the evening. So a 5% reduction for the first month. And then took, in the second month, their first dose down to 75, left the 90 in the evening, and so forth. And so by month 9, they cut the dose in half. So 45 SR every 8 hours. The slower taper, same regimen. So is the starting regimen, morphine SR 90 every 8 hours. And so over a 7-month period in the slower taper, they have you the patient completely discontinuing. And the faster taper takes about 7 weeks. And then in the rapid taper, it takes about 11 days. So you can certainly see the wide range of lengths that this is going to occur over. And again, I would encourage more of the slowest or slower taper type of regimens. Sometimes I think if your patient isn't at risk and they're willing to continue to work with you, slower is better. So even moving to the slowest taper regimen might be good. And then this is a corresponding chart that just shows you from the VA how they follow up with the patient based off of these tapering rates. So the slowest taper or the slower taper, you're going to follow up with the patient in 1 to 4 weeks after starting the taper, and then monthly before each reduction. And who's going to follow up is the PAC team. So this is the prescriber, the nurse for the clinic, and the administrative assistant. And they'll either do an in-clinic visit or telephone visit. And what you're monitoring in this time period is the patient function, probably by the PEG scale, wrapping in the pain intensity in the PEG scale, sleep, physical activity, how they're doing on their goals, their functional goals in particular, and then their stress level. And then with the faster taper, you're working with the patient on a weekly basis. And then rapid taper, it's usually inpatient. You're working with the patient on a daily basis. So any questions before I move to the next slide? Okay. Now, withdrawal. So if you're doing a slowest or slower taper, you're likely to minimize withdrawal symptoms and probably have none with the slowest taper. But if you do, is there something else I can help with? Oh, the phone's talking to me. But if you do have withdrawal symptoms, here's kind of how they break down. So the earliest, and this is from the VA again, the early symptoms of withdrawal usually occur within hours to days, later symptoms days to weeks, and then prolonged symptoms may be lasting weeks to up to months. So the early symptoms, usually you'll see anxiety, the runny nose, kind of that histamine response, insomnia, which lasts throughout the whole time period. Late symptoms, usually you start to bring in the abdominal symptoms. So nausea, vomiting, diarrhea, cramping. So think about how the opioids are acting, and then you're having an overload on the reversal of that. So opioids are going to cause constipation. Now you're going to see a diarrhea. You're going to see very active gut. And so that causes some problems. Also, goosebumps, piloerection is going to be seen a lot in this time period, which can bother some more than others. And then the prolonged symptoms, the irritability, the cravings, especially if they're, you know, have been on it for a long time, whether the craving is something of a substance of an opioid use disorder or just the general tolerance that you've seen. Anyway, yeah. So here is how to rate some of these withdrawal symptoms. It's called the Clinical Opioid Withdrawal Scale. You've probably seen this, COWS for short. There's also a SOWS for the Subjective Opioid Withdrawal Scale that the patient fills out. But this COWS is the one in which the clinician fills out. So after you fill out all this information, then you can rate it. So 5 to 10 on this scale. So you can see how they all add up from 0 to 4 or different, 0 to 5 with different numbers corresponding to the different answer options. So if they have 5 to 12 on this scale, they're mild withdrawal, 13 to 24 moderate, 25 to 36 moderately severe, and greater than or equal to 36, greater than 36 severe withdrawal. So a lot of times the COWS is something in which you can use to guide the dosing regimens of some of the withdrawal medications. Oops. Okay. One more poll question. What withdrawal symptoms are the most problematic for you in tapering, or have you seen for patients in their tapering? So you should still be connected to the poll, and all you have to do is type in, this is free text again, you can type in anything you want. Sweating, yeah, the autonomic response is pretty strong in this, so we'll talk about what to do for that. Craving, yep, it's Yep, those are times to start thinking about, is there an underlying opioid use disorder, or is this just brought on by the tolerance of it over time? Sleep disturbance, big deal. We'll talk about some of the medications you can use for that. Nausea, we'll talk about how to deal with that as well. Okay, looks like some of these anxiety. So you can see some of that being unmasked, whether it's pain catastrophizing or whether it's true anxiety disorder. That's something to think about as well. Body aches, yes, we'll talk about that and how to treat those. And I was able to pull up the chat without getting out of presentation mode. So Ford Baker, I know that I'm noting you said another way to describe this, acute withdrawal or post-acute withdrawal. Many don't understand how difficult post-acute withdrawal can be for some. Yes, that's true. And I don't think we have a good sense. I have a slide in here next, I think, that hints at post-acute withdrawal. And I don't think that we have great data or studies around post-acute withdrawal and what it exactly is. So I think that's a big area of study that we need to focus on. I think inability to sleep maybe is in there. Focus or concentrate. Yeah, that's a hard one too. Nervousness kind of goes along with the anxiety, right? Okay. Okay, so this is from the American Academy of Family Physicians. And so they also split up into early withdrawal, 8 to 24 hours after last use, and then fully developed withdrawal 1 to 3 days after last use. And as you were noting, Ford, about this post-acute withdrawal syndrome. So, and the AAFP does it by grade, and so this fully developed withdrawal with certain symptoms is considered their highest grade, grade 4. So early withdrawal, grade 1, so the rhinorrhea, the histamine response that you're going to be seeing, or the insomnia, the restlessness. Antihistamines work well for this, or trazodone, so Benadryl, trazodone, something along those lines are great. The goosebumps, the muscle pains, the aches, NSAIDs, Tylenol on a scheduled basis are good for that. Loperamide for if it's abdominal cramping pains, or Pepto-Bismol are great too, according to AAFP. Tachycardia, this should be hypertension, fever, all of this, and nausea. So clonidine for these autonomic symptoms. So again, if you're having some of these, the sweating that goes with that, so clonidine is great for that. Or Zofran is typically what I see over the H2 blockers, such as famotidine for nausea. The diarrhea, vomiting, dehydration, loperamide for the diarrhea, rehydrating solutions for the dehydration. And then post-acute withdrawal, again, this is a great area that we can discuss. Currently, what the AAFP is recommending is recovery services and relapse prevention strategies. So I think there's a lot of work that can be done in this area of post-acute withdrawal syndrome. Here's another slide. This is from the VA. VA gets a little bit more specific, includes dosages for their withdrawal symptoms. So the autonomic symptoms that you pointed out earlier, sweating, the tachycardia, so clonidine is usually your go-to. 0.1 to 0.2 every 6 to 8 hours, holds blood pressure less than 90/60. You're probably going to do a test dose of 0.1. You might have this worked already into your order sets within Epic or whatever it might be. So test dose 0.1 with blood pressure check 1 hour later. You're going to have to taper the clonidine if they're using it regularly and reevaluate in 3 to 7 days. Some alternatives for the autonomic symptoms to clonidine might be baclofen, gabapentin, tizanidine. But by and large, Most go with clonidine first, and usually quite effective. The anxiety, the rhinorrhea, can be driven by the histamine response. So hydroxyzine, 25 to 50 3 times a day, Benadryl, 25 every 6 hours. The muscle pains, NSAIDs, again, naproxen or ibuprofen on a scheduled basis, or Tylenol, or if topicals if it's localized. But most of the time, it's not a localized issue. So you're going to have to go with something centrally active. Sleep disturbances, trazodone 25 to 300 at bedtime. Nausea, most of the time we're going to go with Zofran there as needed. Abdominal cramping, sometimes you could even go to Bentyl. I don't see this very often for the abdominal cramping, but it has been effective. And then diarrhea, loperamide, or the bismuth subsalicylate. And here's just another chart on some of those alpha-2 agonists, such as clonidine, and what you might use for those if you're going outside of clonidine. Okay, so here is just a resource that I have of various different opioid tapering tools. So guides or toolkits to kind of like walk you through this. You have some from VA, CDC, and then templates or opioid tapering agreements. So some of these are really great because they're just lined out. You know, here's the medications we're going to use for your withdrawal symptoms. Here's exactly how we're going to taper down. Do you agree to all this? So it kind of helps you get organized in the patient visit. So those are great to just implement in your clinic. Calculators, as far as if you're trying to convert to morphine milligram equivalents to switch them over to another opioid or something like that, you can use the calculators. And then the last thing that I wanted to talk about was this JAMA paper. It was a really short paper. And really the lay title was called Slow and Steady Wins the Race. And so this might be something that you could walk your patient through if they're data detail oriented patients, to really get them on board with the tapering. So the full title of this, and it was a really short article, it was a cohort study, and it was titled Patient-Centered Prescription Opioid Tapering in Community Outpatients with Chronic Pain. And so this was done out of Stanford in a pain clinic out there. And this is some of the latest that we have on this. I'm hoping that I know that they're doing studies right now on randomized controlled trials with tapering. So hopefully we'll have more updated information on those trials once they come out. But I found this one very interesting, so I wanted to tell you about it. So it came out in JAMA Internal Medicine. It was done in a pain clinic. They had 110 patients who were eligible to partake in their study, and 82 of those actually agreed to taper after education. So 75% of those who were eligible agreed to taper. And I would encourage the authors to write another paper about how they got 82 or 75% to agree to tapering, because that's pretty magical right there. What they did is they decreased their opioid dosages by up to 5% through 2 dose reductions in month 1. So this is a very small amount for each of the 2 dose reductions. And the reason they did it this way was to minimize the negative responses of the tapering, as well as, and the withdrawal symptoms, as well as obtain buy-in from the patients. So that month 1 is probably going to become vitally important as you're tapering, because you're in that period building the trust with the patient that this is going to be okay. So then in months 2 through 4, they were asked to further reduce their dosages and up to 10% per week. So that's a really fast taper for some of the patients, but it's certainly tailored by patient. So, but what I do like about this is kind of the structure in which they implemented the tapering. So that first month was very slow, very minimal. Get the buy-in from the patient, and then they can really start moving from there. It's something that's worth considering for your patients. Okay, so this is just the table that they presented on the patients within their trial. There was a cohort study. So I'm going to walk you through this. Hopefully you can see my cursor. They had 51 patients out of the 82 who completed the taper, so went all the way out to 4 months of the tapering regimen, and the rest were dropouts. And so what they first do is compare the baseline characteristics of the completers, those who completed the taper, versus those who dropped out. And what you will see here is that really the only thing that was significantly different between completers and dropouts was their scores on a depression scale. So this is from the PROMIS measure. Those who were dropouts had a higher depression rating than those who completed. So as you might expect, depression is a big deal. And we talked about making sure you're maximizing treatment of that even before you start the taper, because it certainly can hinge, just like we pointed to another study, that depression ratings, severity of depression can certainly be the biggest driver of whether or not your patient completes the taper. For those that completed, the average age was 52. Opioid duration, so they were on it about 6 years prior to tapering, and their opioid dose was on average 288 morphine milligram equivalents. So a pretty good dose on opioids for a fairly long time. What they found, so pain intensity for those who completed baseline on average was a pain score of 5. At 4 months, 4.5. So this was not statistically significant in 51 patients, probably with more patients it would be. But I think this is one indication that you might be able to use with your patients to say, look, we don't think that your pain intensity is going to increase, and it might actually decrease. So this is something to kind of maybe open their eyes about tapering. This PCS is the pain catastrophizing scale. And so it actually went down among completers. So 22 higher pain catastrophizing down to 15 at 4 months. This was statistically significant. So as they're tapering and realizing that their pain isn't getting worse, they're going to probably catastrophize less about their pain. And then the other things, fatigue, anxiety, depression, sleep disturbances, pain interference, pain behavior, pain function were not significantly different between completers, between their baseline and at 4-month time points. And this is probably due to working well with the patient. So they got the buy-in, and then they're treating the symptoms as they experience them, and doing a good job at that probably. For these patients, they did go from, again, 288 morphine milligram equivalents on a daily basis to around 150. So they effectively halved their doses on average in this tapering regimen. Okay, so I'm sorry, we're at, I meant to stop at 12:50 for Central Time, but we're about 3 minutes over. So I want to go ahead and stop here and ask for questions before we do a patient case or two. Any questions?
We haven't seen any come through just yet.
Okay. I'll give you just a second more to think about it before we move forward with the case. Okay. All right. So with this case, I'm going to talk about the case, and then I'm going to ask you to post into chat what some of the options that you might do. Okay. So RW is a 65-year-old mechanic with post-traumatic osteoarthritis and persistent knee pain. He underwent a total knee replacement about 6 months ago, received a prescription for low-dose IR opioid. Post-operatively, after 2 months of daily treatment, the prescription was changed by his PCP to OxyContin, and he's been maintained on OxyContin 60 milligrams BID. He's been actively participating in physical therapy, for postoperative rehab. However, he recently ran out of PT visits. He's willing to consider tapering as OxyContin, so you've won the big step here of getting the patient willing. And he has sleep apnea and a history of depression. He currently takes Lexapro 20 daily, and he says it doesn't help much. So what would you do? Post in the chat for me, or unmute yourself if you can. Tell me, what would you do for this patient? What are some of the things that you would start working on?
We have some answers. Give methadone, crisis counselor,
Mm-hmm.
refer for mental health treatment.
Yep.
Establishing who are his supports. Ask
Yes.
him first if he is currently using CPAP or BiPAP machine to refer to sleep study. If not, enroll him in IOP.
Okay. All right. Yeah, all good options. So there's a lot of things that need to be maximized here before you even start the patient on their tapering regimen. The biggest of which I would say is their lack of response to Lexapro in their treatment of depression. So do we need to try another SSRI? Do we need to switch to an SNRI? What has the patient tried? What have they not tried? Do we need to get them in any sort of therapy along with their depression? So certainly that's one of the biggest things. Someone hit on it in the chat, dealing with their sleep apnea. We don't know from this particular information that we've gotten so far whether or not the patient is treating their sleep apnea, whether it's untreated, have they even had a consultation. So a consultation, a sleep study if they haven't had it, of course, and then also seeing about what do they need. Do they need a BiPAP, CPAP, getting all of that set up before you even start the tapering. They ran out of PT visits, and it seemed to be working because this person was actively participating. So is there some consultation with the PT that you could get for home exercises, education, those types of things for the patient to do at home? Okay. And so as far as his tapering regimen, here's an example of just the slower taper where I did up to 20% every 4 weeks. So they were on 60 OxyContin BID, so bring it down to 50 in the month 1. So a 40 milligram tab and a 10 milligram tab BID, then bringing it down to 40 in month 2, 35 in month 3, 30, and so forth. And so by month 11, you'd have them off if they continued this taper. One other point I want to bring up about tapering that I meant to emphasize earlier, and I probably can't stress enough as well, there's probably going to be events. So like for this patient RW, in the 11-month time period that you're going to be seeing this patient, there's probably going to be events in this patient's life that may cause disruption in the tapering. So let's say they lose a spouse, they lose a parent, or something along those lines. They have some bereavement that they need to go through. What you want to do, because the patient will probably come back to you and say, I need to go back on my dose. I'm dealing with a lot of things, and my pain is out of control because I'm dealing with all these things too, and I need to go back on my other dose. What you really want to try to do is wherever you are in the taper. So let's say that happened in month 3 for RW. Stop the taper right there. Keep the patient at 35 OxyContin BID for an extra month or whatever it is the patient needs. Try not to backtrack in your tapering. Try not to go back to 40. Just stick with the 35 longer than you would have intended until the patient has dealt with the other issues that are going on, and then resume your continued taper. So it's better to do pauses than backtrack in your progress. So I just want to emphasize that in these patients. Okay, and I think we are at the top of the hour, but I'll just say, yeah, so some of other RW's other treatment plans to incorporate before he or she gets going, psychiatrist, psychologist consult, going back to PT for education, on home exercises, CPAP, exercise yoga. What are some of the other complementary health things that you can do as well? Okay, so there's another patient case you can have here. I think there's two more actually, one on fentanyl, one on methadone, that you can work through when you get these slides, but I'll leave those to you. And any questions?
Doesn't look like we have any questions. Naomi, great job. Thank you for the feedback. Okay, well, if we don't have any questions, we will wrap up. Thank you, Dr. Hayes, for giving the first presentation in our series. This was a great start. We had over 60 attendees for this. So everyone that attended, we will send out the slides after the event, as well as an email for the evaluations and information how to receive your certificate. I do see a handful of phone call listeners in. I do not have your information. So if you would like credit for attending, for listening in, please email me with your name, your first name and last name, and what phone number you use so you can receive credit for this. If there's no other questions, we will sign off. And thank you again, Dr. Corey Hayes. This was a great start for our first community opioids.
Ashley.
Yes.
Sorry, before we sign off, give them the email address that they need to respond to.
Oh, email me at ashley@womensfoundation.com. And everyone that attended will receive an email from me as well. And be sure to check out womensfoundation.com/COS for future events. Our next one is going to be on April 14th, and it will be the same format via Zoom. So thank you so much for attending, and thank you again, Dr. Corey Hayes.
Thanks, Ashley. Everyone take care.
Thank y'all.
Bye.